Hello, this is Dr. Vishwakanta Kaur, Assistant Professor, School of Pharmaceutical Science, Soha University. Today I am going to deliver the topic anti-asthmatic drugs. It is one Pharmacology-III theory subject having subject code BP602T. So, in the topic that is asthmatic, so first you know what is asthma. Asthma, actually the bronchial asthma, it is recognized to be a primarily inflammatory conditions, that is inflammations underlying hyperactivity. That means when there is hyperactivity, hypersensitivity produces inflammation in the bronchial tract. A variety of trigger factors, that is infections, irritants, pollutions, exercise, exposure to cold airs, psychogenic factors involves in the hyperactivity in the bronchial, which leads to the inflammations. Along with the mast cells which is present in the lungs and the inflammatory cells recruited as a result of the initial reactions produces a multitude of mediators by the following processes. And the release of mediators stored in the granules, that is histamines, protease enzymes, TNF alpha, which is known as tumor necrosis factor alpha, and release of PG, that is prostaglandins, LT, that is leukotrienes, and PF. So these factors are responsible for the what? The bronchial asthma. So you see in the figures, that is I am showing the two types of one. In the left hand side the normal lungs, muscle is relaxed, normal lining, you see that is what happening, that is the bronchodilations are there in the left hand side. But right hand side you see that is the asthmatic lungs, that is muscle tighten is there, that is excess mucous secretions which produces what? That is bronchoconstrictions. The lining is swollen here, that is inflammations are there. Here in the right, that is excess mucus which produces inflammations which produces the bronchoconstrictions. Whereas in case of the normal lungs you see that the mucous secretion is less and there is no chance of the it produces bronchodilations. Okay, so different, that means when the person suffering the asthma, you can find lot of symptoms, that is wheezings, coughs, softness of breath, tachycardia, difficulty breathings, pale and wet skin, dyspnea, chest tightness. These are the symptoms you can observe. Then if the symptom, that is asthma is there and symptoms are there, then what are the treatment approaches? The approaches of treatments, first one is prevention of antigen antibody reactions, that is avoidance of antigens, that is hypersensitivity, neutralization of antigen, that is reagenic antibody, that is you can, some drugs are there which is known as omalizumabs. Third category of approaches of treatment is suppression of inflammations and bronchial hyperreactivity. Examples are corticosteroids you can use. Prevention of release of mediator like mast cell stabilizer, which can use for the release of mast cells. Antagonism release mediators like leukotriene antagonist, antihistamines, and PF antagonist. Blockage of constriction neurotransmitter, which is known as anticholinergics. Mimicking the dilator neurotransmitter, which is known as sympathomimetics. Directly acting bronchodilator, which is known as methylxanthines. Come to the classification of anti-asthma drug. First category of drug is bronchodilators. Under these two sub-classifications are there. One is beta-2 sympathomimetics. Examples are salbutamol, terbutaline, bambuterol, salmeterol, formoterol, ephedrins. Methylxanthine derivatives, examples are theophylline, aminophylline, choline theophyllinate, hydroxyethyl theophylline, theophylline ethanolate of doxophylline. Anticholinergic drugs, that is ipratropium bromides, tiotropium bromides. Number 2 category drug, the leukotriene antagonist. Examples are montelukast, zafirlukast. Mast cell stabilizer, examples are sodium chromoglycolate and ketotipenes. Corticosteroids, examples that is under this systematic corticosteroids and inhalations we can use. In the systematic, examples are hydrocortisone, prednisolons. Inhalations, that is beclomethasone dipropionate and budesonide, fluticasone, propionate, that is flunisolonides and cyclisonides. Last one is anti-Ig antibody, that is omalizumabs. First come to the first category of drug, which is known as sympathomimetics. The sympathomimetics, these are adrenergic drugs which causes bronchodilations. It's act to the receptor which is known as beta-2 receptor, stimulate so that the secondary translation mechanism that increase the CMP formations in bronchial muscle cell which produces the relaxation, that is bronchial relaxations. In addition to increases CMP in mast cells and on the other inflammatory cells, it decreases the what? The mediator release. Adrenergic drugs that mainstay of treatment of reversible airway obstructions, so they are most effective and fastest acting bronchodilators when inhales. Adrenalines, that is beta 1, beta 2 alpha receptor agonist, and isoprenalines, beta 1 plus beta 2 agonist, are effective bronchodilators, and it is selective beta 2 agonists that are now used in asthma to minimize the cardiac side effects. Example is salbutamol, which is brand name is albuterol. It is a highly selective beta 2 agonist. When used in inhalation forms, delivered mostly from pressurized meter dose inhaler, that is PMDI, and produces bronchodilations within 5 minutes, and the action lasts for the 2 to 4 hours. Therefore, it is used to abort and terminate attack of asthma, but is not suitable for the round the clock prophylaxis. That means you cannot use for the part that is round the clock, that is immediate purposes. Side effect: the muscle tremor are the dose related side effects. Palpitations, restlessness, nervousness, throat irritations, ankle edema, and hypokalemia are the common side effects. Pharmacokinetics: it undergoes pre-systemic metabolism in the gut walls. Oral bioavailability is 50%. Oral salbutamol, that is act for 4 to 6 hours, is longer acting and safer than the isoprenalines. Dose is 2 to 4 milligrams orally used, and brand name is Dastarin 100 microgram meter dose inhalers. Next category drug is anticholinergic drugs. It is known as the atropinic drug, which causes bronchodilations by blocking the M3 receptor mediated cholinergic constriction tones, and act primarily in the larger airway. So, in the bronchial tract, larger airway, smaller airway there. In the smaller airway, generally the salbutamol drugs are acting, whereas in cases of larger airway, that is M3 receptors acting. So, hence the ipratropium bromide is a short acting drug having duration is 4 to 6 hours. Inhale anticholinergic bronchodilators, while tiotropium bromide is long acting, duration is 24 hours. Both are less efficacious in comparison to bronchodilators. Combination of inhale ipratropium with beta 2 agonist produces more marked and longer lasting bronchodilation since their effects are additives. You can find in the marketed formulation, that is salbutamol ipratropium, that is known as duoline inhaler, 100 microgram plus 20 microgram per meter dose in the market. Third category of drug, which is known as methylxanthines. Theophylline is the most important drug of choice, which is obtained naturally. It is methylated xanthine alkaloids, that is others are caffeines and theobromines. Mechanism action of methylxanthine is releases calcium from sarcoplasmic reticulums, especially in the skeletal and cardiac muscles. Along with also it inhibits the phosphodiesterase, which degrades cyclic nucleotides intracellularly, and the concentration of cyclic nucleotide is increased. Hence, the bronchodilations and cardiac stimulations and vasodilation occurs when CMP levels rises in the constant levels. Okay, so methylxanthines is mainly acting on the where the phosphodiesterase enzymes. Okay, that means it inhibited the enzyme so that the level of high cyclic nucleotides are increases. Come to theophylline, you see theophylline pharmacokinetic. The pharmacokinetic of theophylline, that is in come to absorptions, absorb orally, distributions, distributed in all the tissue, crosses placenta, secreted in the milk, having volume distribution 0.5 liter per kg, 50% plasma protein bounds, metabolized in the liver by the process of demethylations and oxidations, primarily by the CYP1A2 enzymes. Excreted 10% excreted unchanged urines. Its elimination rate varies considerably with the age. At therapeutic concentration of the theophylline, the T-half in adult is 7 to 12 hours. Children eliminated much faster, T-half is 3 to 5 hours, and elderly more slowly. In premature infants, the T-half is prolonged, that is 24 to 36 hours. We are discussing the elimination kinetic because the drug metabolizing enzymes are saturables, that is T-half is prolonged with higher doses as kinetic changes from fast order to zero order kinetics, so the plasma concentrations are increasing disproportionately with doses. Uses is bronchial asthma and COPD, that is chronic obstructive pulmonary disease, apnea in premature infants. Then comes the nicotine antagonist. We know LT antagonist. Two types of drugs are there: montelukast and zapirlukast. They competitively antagonize the cysteine nicotine receptors, mediate bronchoconstrictions, airway mucus secretions, increase vascular permeability, and recruiting the eosinophils. So they are indicated for the prophylactic therapy of mild to moderate asthma as alternative to inhaled glucocorticoids. The efficacy is low, but in severe asthma they have additive effect with inhaled steroids and may permit reduction of the steroidal dose and need for the rescue beta 2 agonist inhalers. That means they will combine with the steroidal drugs. And they are also additive with the long acting beta 2 agonist is a greater way. Side effects: the main side effects are that is headache and rashes, and few cases produces the Church-Strauss syndromes. Pharmacokinetics: absorbed orally, high plasma protein bound, metabolized in the CYP2C9 and CYP3A4. Plasma half-life of the drug montelukast is 3 to 6 hours, whereas zapirlukast is 8 to 12 hours. And the common brand name in the market are Emulukast, Monter, Venter, and zapirlukast is Jovers. Come to the mast cell stabilizer. Here two category drugs are there. One is sodium chromoglycolate. It is a synthetic chromone derivatives which inhibit the degranulation of mast cells as well as other inflammatory cells by triggering the stimuli. It is also not a bronchodilator and does not antagonize the constriction action of histamine, acetylcholine, and nicotine, etc. Therefore, it is ineffective if given during an asthmatic attack. Pharmacokinetics: it is not absorbed orally. It is administered as an aerosol through metered dose inhaler, delivering 1 mg per dose, 2 puffs 4 times a day. Uses: it is mainly used for treatment of bronchial asthma, for long-term prophylactic in mild to moderate asthma, and also used for treatment of allergic rhinitis. That is, chromoglycolate is not a nasal decongestant, but regular 4 times a daily use as a nasal spray produces some symptomatic improvement in many patients after 4 to 6 weeks. Third uses is allergic conjunctivitis, and you can find the brand name written on the pintle. Last category of drug, that is ketotipenes. Under the mast cell stabilizer, it is an antihistaminic with stimulation of immunogenic and inflammatory cells, mast cells, macrophages, eosinophils, lymphocytes, neutrophils, and mediator release are reduces. It is not a bronchodilator, it produces the sedative effect. But after prolonged use of the ketotipenes, the modest symptomatic reliefs may occur in some patients of bronchial asthma, atopic dermatitis, perennial rhinitis, conjunctivitis, urticaria, and food allergy. Adverse effect: common adverse effects are dry mouth, dizziness, nausea, and weight gains. Dose is 1 to 2 mg BD, and you can find the brand name in the market, that is Asthafen, Ketovent, Ketorides. Last category drug for the asthma is corticosteroids. Glucocorticoids are not bronchodilators. They benefit by reducing the bronchial hyperactivity, mucosal edema, and by suppressing the inflammatory response to antigen-antibody reactions. It improves the airflow, reduces the asthma exacerbations, and may influence the airway remodeling. The systemic steroid therapy is used in two conditions. One is severe chronic asthma not controlled by the bronchodilators, and inhaled steroids start with penicillins at the dose of 20 to 60 mg daily. Second uses is status asthmatics or acute asthma exacerbations, asthma attack not responding to intensive bronchodilator therapy. That means previous drug not used. Here in that cases, status asthmaticus start with dose of rapidly acting IV glucocorticoids which act 6 to 24 hours, shift to oral therapy for 5 to 7 days, and then discontinue the therapy. Inhaled steroids: the beclomethasone, dipropionate, budesonide, and fluticasone, the cyclosonides, they are indicated in all cases of persistent asthma when inhaled beta 2 agonist required almost daily or the disease not only episodic. Start with 100 to 200 micrograms BDs. Okay. So this is about the asthma. In the next class, we discuss some other drugs.